Good morning, everyone. Should we start the class?
Good morning. Happy New Year to all of you. And Prabhat, you can go ahead.
Okay. Hemant, start presentation.
Yes.
Hello. Okay.
Sir, I am presenting in the name of Ravi, sir.
Try sharing screen now.
There is my screen visible, sir.
Yes.
Good morning, everyone. Today, today's discussion about a 16-year-old male, a resident of Thane who is student, presented with a swelling over right thigh of 3 months duration. The swelling is progressively increasing in size, associated with pain on and off. There was no history of trauma, no history of fever, or no history of weight loss. No past history of medical or any surgical history. There is no history of tuberculosis. Patient has no family history of cancer, no history of any addictions. So on examination, ECOG PS1, their mental functions were intact, vitally stable, no palpable neck nodes. Respiratory system was normal. The CVS is normal. Per abdomen was soft, non-tender, and no palpable mass. And local examination showed approximately 10 by 8 centimeters mass over right thigh dorsal aspect over upper third of femur with ill-defined margins fixed to underlying structures. It was non-tender and there are no signs of inflammation. The right lower limb movements were within normal limit. There is no restriction of movements. There was no sensory motor deficits. And the range of motion at the hip and knee joints, there was no restriction. Distal pulses were palpable. With this, my differentials will be soft tissue sarcoma and bone tumor. Shall we?
So, Hemant, you said over the femur.
Yes, sir. Femur
You should have used word over there, thigh, right?
thigh, yes.
Hi, this is Dr. Gulia here.
Upper one-third thigh.
Upper third of thigh, yes.
Okay. From your clinical examination, what will you keep first, bone tumor or a soft tissue sarcoma examination?
I think Dr. Gulia wanted to say something.
Yeah, Hemant.
Good morning, sir.
Good morning. So, as Dr. Prabhat rightly said, you should not be talking about any specific bone. You should be, because it is your examination part and you have not tried to differentiate whether it is arising from the bone or the soft tissue. So you should not be particularly talking about any particular bone. You should be mentioning an area. Okay. In
Yes.
addition to that, it is always advisable to use some landmarks, bony landmarks, that the swelling is located so many centimeters down from the iliac spine or the iliac crest, or it is extending 5 centimeter to 10 centimeters. So it is always good to give those dimensions of the swelling as well.
Yes.
And just a general advice, whenever you are talking about any limb swellings and cases like that, just make a small format from SDAS, which is very crisp also, and will give you inspectory and palpatory findings. Okay.
Yes.
So the swelling, whether it is globular, so basically the size of the swelling, the number of the swelling, whether its edges are well defined or not. So there's a very small format. Just note that down. It will help you in all those patients.
Yes,
And
sir.
as you have written in your DD here that it is arising from bone tumor or soft tissue sarcoma. So if you mention that it is arising from femur, then you are contradicting your own statement.
Yes, sir. Understood.
Yeah. Okay. And I will just complete it so that I don't interfere with you. Also, whenever you get such a limb case, I know as a part of medical oncology exam, we don't expect detailed examination of the joints, but it is good to know at least range of the movements, that what is the normal hip range of movement, what is normal knee range of movement, and whether range of movements are restricted and how much.
Yes.
Okay, good.
So basic investigations like blood workup, CBC was normal, RFT serum creatinine was 0.78, sodium potassium were 144.5, LFTs were within normal limits, LDH was 206, and the serum alkaline phosphatase is 166. Slightly.
So why did you do LDH and alkaline phosphatase?
To know
And
the
again, as a dictum in the exam, whatever you mention. So 80% of the questions in the examination are asked from what you utter in the examination, what words you use, what you present. So you should be very careful in telling whatever you are mentioning. So if you're mentioning any investigations, any blood investigations, you need to know the rationale behind doing that. That is very, very important.
Yes.
And if there is none, then and if it is something which is not very important, then you may just omit that. And if specifically asked, then said yes, we have done that. So please now here, if you can elaborate on why did you do these investigations and what is the rationale behind it?
CBC, RFT, and LFT and sodium potassium to know the fitness for know the fitness for chemotherapy. LDH to know the disease burden. Serum alkaline phosphatase is also usually elevated in bone.
So does that have any significance?
It's just a prognostic later on.
Are you sure? So read about it. It's a very, very weak prognostic marker, but yes, you can. There are a few studies which can substantiate that, but you need to read more about it. Also, in addition to that, you must always talk about coagulation profile also.
Yes.
Yeah, good.
Why will coagulation profile be necessary, Hemant?
If you want to take biopsy.
Yeah. So you should not miss it.
Okay. Based on your history, what one differential will you come? Bone tumor or a soft tissue sarcoma?
Bone
Go
tumor.
back to your history. Why?
CP is slightly elevated.
What is elevated? ALP.
Serum alkaline phosphatase is slightly elevated.
Hemant,
Okay. How much do you expect in a bone?
Serum alkaline phosphatase will not guide you to tell whether it's a bone tumor or a soft tissue tumor. It has to be end of your history and examination.
Yes.
So this is what exactly I was telling you, that you should not be mentioning the site. If you present like this, an examiner knows that you know the case.
Yes, I understand.
Okay. Now you tell me your findings. So I am saying it is soft tissue sarcoma, and I'll prove it to you with your findings only. You disprove me that it is a bone tumor.
Based on examination findings, soft tissue sarcoma or bone tumor are still two differentials based on history and examination.
No. You have to differentiate it. You can't say like that. That means at the end of your local examination, you are not sure whether you are dealing with a soft tissue sarcoma or you are dealing with a bone tumor. So anyways, let's not waste a lot of time here. But again, I'll reiterate that just read ASDAS. It has some 7 or 8 points. And you just need to know that. Was the swelling moving with the movement of the underlying bone? You know?
Yes, sir.
Was the swelling fixed or mobile from the underlying structures?
A swelling.
Hello? Am I
Sir.
audible?
Yes.
Okay. So
Yeah, so these
Yes,
are
sir.
the
Yes, sir.
points. Yeah, these are the points you need to write down and mention in your examination. These are extremely important because based upon those findings, you will order further investigations. You can't say randomly that I'm ordering all these investigations, because you need to have a clinical examination, a clinical diagnosis. Sorry, at the end of your clinical examination.
Yes.
No, nobody is going to ask you whether it's a osteosarcoma or it's a Ewings sarcoma or it's a chondrosarcoma. But at the end of your clinical examination, you at least must be able to differentiate whether it's a soft tissue sarcoma or a bone sarcoma. Okay?
Yes.
ठीक है.
Okay.
So
Go ahead,
make sure everyone who's listening, make sure whenever you present the next class, you must be able to differentiate that with those specific points. Go ahead.
So this is the X-ray showing periosteal reaction in the form of elevated periosteal, proximal end of the femur, proximal diaphysis of the right femur.
No, so again, for all the students, it is very, very important to remember that you need to know how to read an X-ray. Okay? You can't say, if you put an X-ray, you just can't say there is a periosteal reaction. That is not the way, and this is not expected. If you have a bone tumor patient, if you are reading an X-ray, there is a methodology. How do you read an X-ray? And that has to be clearly mentioned by you, and ideally speaking, it should come out as one sentence. Okay? So the dictums are, you need to know about the lesion. You first start with what sort of X-ray it is, which areas are visible in this X-ray, where is the lesion located, what is the kind of lesion. Then you talk about periosteal reaction, zone of transition, any matrix if it is visible. Then once you have mentioned about it, then you go whether there is a pathological fracture or not, any joint involvement or not. So that completes your bone part. Then you also need to mention about what is happening in the soft tissue as well. Okay? So this is the way you need to mention all these points. And trust me, if it's not very difficult. And if you mention that, it gives a very, very nice impression to the examiner that you know how to read X-ray, and absolutely you will fetch more points there. Okay? I think
request
Amit is also here, na?
Yes, sir.
Yeah, Amit, can you please elaborate a bit more to them what all these points, how all these points which I mentioned can be, explained to the examiner. Amit, you are around?
He is online and there would be some problem.
Okay, no problem. So anyways, I'll just read this X-ray for you so that everybody understands how to read X-ray, and maybe you can practice on a few X-rays in the OPDs or in the wards. So this X-ray is including both the hip joints with both the femur, upper 2/3. There appears to be a lesion involving diaphysio and upper metaphyseal lesion on the right femur, which extends right from the lesser trochanter till mid diaphysis or maybe even longer. The bone is undulated and there is thickness of the cortices. I cannot appreciate any clear matrix. The issue is that this X-ray which you have put here, I think it's post chemo X-ray. So, and that's why you see so much of thickness of the cortices. If you have put pre chemo, then you would have got more soft tissue and you would have got more onion peel sort of appearance in this X-ray. But anyways, so that is the thing. There is no pathological fracture. There isn't any joint involvement or any skip lesions. Soft tissue appears to be normal. So that's how you will read this X-ray. Okay.
Yes,
So
sir.
is this a post chemo X-ray?
No, sir.
Post
This is before chemo.
Unlikely, no? Unlikely. Okay, anyways. So that's how you are going to read this X-ray. So I don't see any matrix. Zone of transition is also not very clear in this. And what is the age of the patient you said?
16 years.
16 years.
Yes.
Are you sure?
Yes, sir. 16.
Because on X-ray, physis and everything looks fused. Okay. So now based upon this X-ray and whatever findings I have told you, what is your first differential?
First differential would be Ewings.
Because you know the case.
No, sir. Appearance, it's like Ewings and osteosarcoma are the two differentials.
Okay, why not osteosarcoma then? Why did you say Ewings?
Osteosarcoma usually arises from the metaphysis and it looks like, elevated periosteum, like Codman triangle, or appearance will be like sunburst.
Okay. So essentially, if you say second decade, 16 years, 18 years, you've seen a lot of osteosarcomas in the diaphysis. There is no clear-cut onion peel appearance here. There's a bit of Codman triangle. So how can you say that it is Ewings and it is not osteo? Hello? Yeah. So basically, first is the location. Yes, it can be osteosarcoma, but at this location, Ewings sarcomas is more common, and hence I am putting Ewings as my first differential. So that's how you should set. And I still, I'm not really sure that this is. Anyways, no worries. Also, very important point which you should know is the soft tissue component in Ewing sarcoma is usually much more than the osteosarcoma. Okay.
Yes.
Third thing is, in this X-ray, there is no soft tissue ossification happening, which is an hallmark of osteosarcoma. Correct?
Yes.
So these are the points which will help you to put Ewings as first differential and osteosarcoma as second.
Yes.
Okay.
Yes.
So this is how you need to read an X-ray, and always try to give differentials. Don't get stuck onto one diagnosis.
Yes.
I think
Okay.
Dr. Amit Janu may be audible now.
Hi,
Amit
Amit.
Janu, sir, can you hear us? Okay. There seems to be issue on his side.
Hello.
No problem. No
Yeah.
problem.
Hello.
Yes,
Hi,
sir, Amit,
Amit.
sir. Yes, sir.
Hi. So I agree with the finding that Dr. Guli has already said. So we will see that it is there is a large soft tissue component, and we don't see any osteoid matrix. So if there is no osteoid matrix and no cartilaginous matrix, then we think that there is some tumor which is not producing any matrix. So among malignant tumors, there are very few tumors in this age group that will not produce the matrix. So that is peanut is one of the, or Ewing sarcoma is one of the commonest malignancy that will not produce any matrix, and it will have aggressive periosteal reaction like in this case.
Okay, Hemant. So Hemant, now you tell, you have done X-ray. What do you want to do ahead? How will you manage this patient?
want to do the MRI to know the exact local extent of the tumor. And
And why do you want to do MRI and not CT scan? CT scan is cost effective. CT scan is easily available, and it can be done, very quickly. While MRI takes sort of time. So why not CT scan?
it has soft tissue component is involved, and MRI can read better. I mean, regarding neurovascular bundle involvement, MRI will be better.
No,
model.
we can easily see neurovascular bundle on a contrast CT. Am I correct, Amit?
Yes, sir, correct. So basically, there are some other things which we want to see on MR. Specifically, because it is a bone tumor, what is the extent within the bone? So that is very difficult to assess on the CT. How much the marrow infiltration is there, whether there are any skips. So ultrasound is very, MRI is very sensitive in picking up those marrow lesions, even on without giving contrast.
Okay, you got the point?
Yes, sir.
So it is not just the relationship to neurovascular bundle. Neurovascular bundle can be seen on a CT as well, but it is the extent of the disease, whether in the soft tissues and especially in the marrow. Looking at the skip lesions, MRI is extremely sensitive. So if you really want to plan your surgery, if you really want to know the extent of the disease, MRI is the investigation of choice.
Yes, sir.
Okay, go ahead.
This patient MRI was done and it showed mass lesion seen in the proximal femoral diaphysis with the periosteal soft tissue component in the anterolateral compartment. Proximal and distal aspects of the lesion are 5.6 centimeters and 23.5 centimeters respectively from the tip of the graded trochanter. Femoral neurovascular bundle is uninvolved. Skip lesions are seen involving the right tibial proximal epiphysis and left supraacetabular lesion.
So Hemant, I mean, you have read the report which was there on that, so that's not of much significance. But you tell me, will you get an MRI with contrast or a non-contrast MRI? So MRI, these are the practical questions which are asked in the exam also. That's why I'm asking. You should be very clear about it. If you want to give a prescription for MRI for this patient, which you showed the X-ray, what will you write in that prescription? Just tell me that. You want to send this patient to Dr. Amit Janu and you want to raise a prescription. What are you going to write in that prescription? It is not difficult. You do it every day in the OPD.
MRI, right thigh, plain and contrast.
Plain and contrast.
Yes.
Anything else? Anything else? Hi Amit, if you can chip in here, how would you, what all information you will need and how an ideal MRI should be done? If you can elaborate, please.
Yeah, so we will see that again, we have seen that there is a skip lesion and there are other things that we have picked up. Basically, when we do an MRI, we want to see what is the cellularity of the tumor if we want to take a biopsy. So for that, we need additional information apart from routine pre-contrast and post-contrast imaging that are helpful in deciding the active area of the tumor for the biopsy planning. And then there are some times when we are in doubtful regarding the indeterminate lesions, because there are many other lesions which might throw up during when we are actually screening for the limb. And for these lesions, sometimes for characterization, we need diffusion weighted just to see whether the lesion is having the same cellularity as the primary mass, or the in-phase out-phase imaging, in which it will tell whether it is an inflammatory lesion or a normal marrow reconversion or a marrow metastasis. And sometimes in case of dynamic, that we usually need it for osteoblastoma, but it is also helpful in other conditions also if you want to target the lesion in a particular way.
So essentially, in your prescription to MRI, you always need to add a short clinical history, because sometimes radiologists may not be able to access your findings on the EMR, and you may be sending it to somewhere outside. So it is always very important that you write a couple of lines about the history and the presentation of the patient. You must ensure that you ask for scanning of complete bone, because as Dr. Amit mentioned, there will be some skips and we need to look at those and differentiate those. Many times we get a lot of MRIs from outside where only half the bone or half the lesion is scanned. So it is very important to scan the entire bone. Amit, can you please teach the students how to read MRI? There are a couple of images which are present, and based upon this MRI, what will be your radiological diagnosis?
Yeah, so we see that what we have seen in the X-ray, that the lesion is corresponding at the same site in the proximal femur where it was there. But if we see that there is a large soft tissue component on the lateral aspect of the femur that is there, and if we see on the STIR, there is some associated edema. So STIR is the full length image that we usually do for picking up the lesions, and then to characterize these lesions, we need the full limb T1 weighted images to know the marrow extent and other skip lesions to confirm the findings. So here there are two images. One is the T2, which is showing the soft tissue component and the marrow involvement. Second is the STIR, where it is showing all the bright area that is within the marrow and outside the soft tissue is the disease. So this is the amount of information. Second thing, neurovascular bundles, actually the darkness of the image is too high, otherwise you can actually trace the neurovascular bundle. It is in the continuous path, and when you scroll up and down, actually you can trace those neurovascular bundles. They are lying in a specific locations. Second thing we want to see about the nodal disease, whether usually sarcomas are not having nodal metastasis, but still if there is a some metastatic node, it will change the entire outcome of the patient. So we want to pick up those nodal disease here as well. And if there is any other bone, we will see there is a lesion, whether it is a metastatic or not, that we have to confirm on the STIR and even post-contrast imaging, and then we do a dedicated MRI of that area, or we do biopsy from that area. I think Dr. Wille, it is that sufficient?
Yes,
Yes,
it is good enough. And as we were talking about looking at the X-ray, now I think you can correlate, as I was saying, that the soft tissue component in Ewings is much more. So here you see that the bone involvement there is, and it has such a big soft tissue component. So most of the Ewings sarcomas will have this picture, and this can be one of the differential points. Great. Yeah, Hemant, go ahead.
So histopathology of this showed it is a malignant round cell tumor. On IHC, they are positive for MYC2 and negative for synaptophysin and desmin. This impression, it is a malignant round cell tumor compatible with Ewings sarcoma, and interface fish showed positive for Ewings sarcoma R1 gene rearrangement.
Is Poonam around?
Before, sir, I would like to ask you, how would you approach for biopsy for this patient first? Then we will go to Poonam, ma'am.
Great. So, Hemant,
Sir.
Please tell me. Just open that MRI image again. Just go back. Yeah. Now you tell me. I know you don't do biopsy, but you must know how these surgeons do biopsy. So please tell me which area you would like to target, and how would you do the biopsy, and what kind of biopsy? Any idea about it? If you don't have, let me know. Let's not waste time.
Not sure.
Okay. So essentially what you need to understand is that biopsy is taking a small core of the tissue of the tumor tissue, correct? Now there are essentially two ways to do it. Either we make an incision, open it, and then take some tissue, that is called as open biopsy, or we give a small nick, introduce a needle, and then take the tissue. That is called as needle biopsy. Very simple. Now, needle biopsy is preferred over open biopsy, given the reasons that it is an OPD procedure, doesn't require anesthesia, doesn't require hospitalization, can be done with a small nick with a needle, where you can take multiple cores from the tumor, whether it is in the bone or it is in the soft tissues. Whenever we do final surgery, we have to excise this scar which is produced, and the track also, which is produced by biopsy. So obviously, if you do an open biopsy, you will have a lot of contamination happening in that area, and all that area will have to be excised. And needle biopsies hardly have any complication rate or any infection. So hence, needle biopsy or a core biopsy is preferred over open biopsy. Exceptionally, if multiple core needle biopsies have resulted in a negative report or a report which is not matching with the clinical and radiological diagnosis, we might go for open biopsy very, very rarely. In TMH, we may be doing just 2 or 3 open biopsies per year. That's it, after seeing so many patients. Now, another very important point is, what should be the location from where we should do biopsy? So for that, we must remember that we need to complete all our imaging, that is all our local imaging, that is X-ray and MRI, before we plan biopsy, because as I mentioned that the biopsy scar need to be excised during final surgery, it has to be placed on that incision which a surgeon will be taking for the complete excision of the tumor. Okay, so what it actually means is that I will be planning my final surgery today and then putting that biopsy scar on that area. Typically in this patient, I would like to take a lateral approach, and hence I would like to do a biopsy from the lateral side. Now, many people ask whether we can take the soft tissue core or we need to go to the bone also. If you can avoid, if you can understand your MRI very well, and if you can avoid the necrotic areas, even the soft tissue component of the bony tumor like Ewings sarcoma or osteosarcoma will give you adequate information with which you can diagnose. But if you have obviously bone there, you can take the bone, because necrotic areas are more common in the soft tissue component. So you must avoid that and you must take adequate course. When you send the specimen for biopsy, please do not divide the specimens. This is a very common practice outside, which people do, that we want opinion from 2 centers. So they will divide the samples and send to 2 pathologists. So, you know, sometimes because sarcomas are heterogeneous, few cores may show high areas and few cores may show low areas, and specifically not in Ewings, but it may happen in osteo or chondrosarcoma, where it becomes very, very difficult later on. So if you want a second opinion, first you send all the specimen to one lab, get it processed, and then if you want second opinion, you can send slides or the blocks to the next lab. So this is how, in short, you know, you need to know a few points about biopsy. Is that okay, Prabhat?
Yes, sir. Yes, sir. Thank you.
Yeah.
Now we will go ahead with Poonam ma'am, if she can throw some light on biopsy of patients with suspected Ewings sarcoma.
Sure,
And
am I
Poonam,
audible?
please, yeah, Poonam, please also elaborate that what is the need for FISH and why do we do it, and do we need to do in all the patients, so that students can,
Sure.
remember that.
Sure, sir. So good morning, everyone. And like Dr. Gulia has correctly said that one practice we should not follow is dividing the biopsies. And when it comes to pathology, sometimes when there is a tumor that we know will require a lot of molecular, at our end in the lab, what we do is that we split the biopsy cores. If we are getting multiple cores, instead of putting everything into one block, we divide them into 2 blocks, especially for lung cancer. We do that very routinely so that the material doesn't get depleted in one block itself. So that is something that can be done, but definitely not dividing between labs. So when we look at a biopsy report which says a malignant round cell tumor, so it is a very broad spectrum. Like a round cell tumor can encompass so many different types of tumors. So as a pathologist, when we look at a round cell tumor, the most important thing that we need is the age and the imaging findings. Especially when it comes to bone soft tissue, I think without these two, the clinical and the radiological findings, I think we cannot give a definite report, because we need to know what is the radiology, what is the suspicion, and is it matching with the suspected diagnosis. Can I share a few slides here?
Yes, ma'am.
Yeah, so please let me know if it is visible.
Yes, ma'am.
Yeah, okay, thank you. So yeah, like I said, let's skip the theory part, but we just need to know that Ewings sarcoma is very common in the second decade and second most common primary malignant bone tumor after OGS that we see. Now, this is how a biopsy would look. Now, I know that probably pathology description may not be really relevant for the exam going students here, but if you could appreciate here is, what are you seeing? Can anybody just tell me vaguely what they are seeing? Anything that comes to your mind? Can anybody say, I don't expect you to give me proper things, but can you just tell me what is it that you're appreciating at this, in this image?
Hemant. Hemant.
Okay, if he's not around, then maybe I would just like you to know that if you can see here, it is all a very monotonous, uniform, blue looking cells. I hope everybody can appreciate that. So all you can see is this sheet of blue cells, and that's it. So that is what we so commonly refer to as a malignant small round blue cell tumor. And there are many things that can look like this. That is where the difficulty arises. And that is where the need for ancillary techniques comes in. So here, this is a malignant round blue cell tumor. The higher power of this, we can see that all the cells, if you can see my cursor here, all the cells look pretty similar. They are blue cells with, hardly any cytoplasm. The cell borders are not very clear. And all these small blue dots that you see in between are nothing but apoptotic debris. The cells are dividing fast and they are undergoing apoptosis. So these all in between things are the apoptotic debris. So this is all you see in your biopsy. And here I just would want everybody to have a note of this. Can you see this part of the image? Is my cursor seen?
Yes, ma'am.
Yeah. So see, this is on the right side, you can see a tumor, and on the left side, you're seeing something that looks very crushed. This is what you will commonly see in our reports, that crushing artifacts and a lot of crush necrosis, crushing artifact. These tumors are very fragile and they do undergo a lot of crushing. And if the biopsy predominantly shows these artifacts, sometimes we are at a loss at what to give. So we do make a mention of that. If there is too much of crushing artifact, IHC also may not be very helpful. It may not be a correct pattern. Because of this crushing, the IHC patterns may be very vague. So this is something that we always make a note in our biopsies. So, and we hope not to see this, like we would not want to see a tumor with a lot of crushing artifact. Again, this is what is we describe as a rosette. If you can see, there's a central part here, pinkish appearing thing, and the cells are arranged around it. So many a times these rosettes are seen in primitive tumors, childhood tumors, Ewing sarcoma. Around a central thing, the cells are radiating. Otherwise, it is just this homogeneous kind of cells with occasional mitotic figures. So having a blue cell tumor if I don't have access to any IHC, then probably I can just give, like, probability can be, it could be a Ewing sarcoma. It could even be a lymphoma. It could be a small cell osteosarcoma. It could be a small cell carcinoma in a given clinical context. So based on H&E, there will be a lot of differential diagnosis. Okay, neuroblastoma, rhabdomyosarcoma. So here is where we require ancillary techniques. When it comes to Ewing sarcoma, we have this marker called MYC2 or CD99, which is very helpful for us to determine the diagnosis. If you look at anything brown in IHC is considered positive, and we look at the pattern of expression. Now, these two images will tell you nicely. The image on the left is showing this nucleus in the center, which is negative. And what is staining here is the cell membrane. Nicely, it is outlining the cell membrane and some cytoplasm. Nuclei are negative. This pattern, a strong membranous positivity for CD99, is considered to be diagnostic for Ewing sarcoma. And I want the residents to know that having a report which says CD99 positive tumor does not mean anything. Now, CD99, that marker is said to be staining 99 different things in pathology. There is a whole list of tumors that can come positive. So what is important? You should look at the report, whether it says a strong, diffuse, membranous expression. This is very critical to know. If it describes a strong membranous expression of CD99, and if there are other markers done, it is highly suggestive of an Ewing sarcoma. The use of CD99 is that if a tumor is negative for CD99, it is less likely to be Ewing sarcoma. So that is where, though it is not a specific marker, it is very sensitive, and the pattern of expression helps. Along with CD99, we use other markers like flavin. Now here you can appreciate that the nuclei are staining as contrast to this membrane. So flavin is a nuclear marker which comes positive in Ewing sarcoma. And thankfully, we now have a more specific marker, which is called NKX 2.2. This is a transcription factor which comes positive in Ewing sarcoma. It is a downstream target of EWS flavin. The specificity of this marker is more than CD99. And though there are certain other tumors like mesenchymal chondrosarcoma, bone tumors, which can express NKX 2.2, combining the histology and this IHC expression, strong nuclear positivity for NKX 2.2, on IHC, we can be fairly sure, like if I have a case which on radiology fits into Ewing sarcoma, the age is typical. On IHC, we are seeing a small round blue cell tumor, and IHC shows a strong membranous CD99, MYC2 positivity, along with flavin and NKX 2.2. I think we can be fairly sure it's Ewing sarcoma. So in such a case, probably there would not be a need for doing any other molecular tests. But like I said, tumors don't always come with a perfect markers, perfect expression. And sometimes even an Ewing sarcoma can have atypical histology. Plus, a lot of these, plus there are a lot of other sarcomas, round cell sarcomas, like Ewings sarcoma.
Devanshi, mute yourself.
Yeah, thank you. Okay. So there are a lot of other sarcomas which can come in the undifferentiated round cell sarcomas, can have other entities like a Ewings sarcoma, chick duct sarcoma, and sometimes even the distinction between a small cell OGS and Ewings may not be possible if the IHC is not helpful. In those cases is where we would like to go in with molecular diagnosis, and then we ask for an RT-PCR or a FISH so that we can get an EWSR1 rearrangement confirmed on molecular. So T translocation 1122 is the most common translocation, which will give rise to an EWSR1 flavin fusion. The second one is the EWSR1 ERG fusion. There are a lot of other translocations also which are present, other fusions. We need not go into details of that. But if in doubtful cases, we get either an RT-PCR showing an EWSR1 gene rearrangement or a FISH. Here there's a break-apart probe which shows that there is a gene rearrangement of 22 Q12 and this break apart probe. This is a normal fuse signal, and these two signals are showing break apart rearrangement. So in these cases where IHC is not helpful, we may resort to doing molecular testing. So I hope that is clear, and I would be happy to take any doubts. Thank you.
It's clear, ma'am. Thank you.
Thank you.
Hemant, back to you.
Yes.
If you're confident with IHC and morphology, then there is one to fish. That's what the carry home message.
Yes.
This patient PET-CT showed hypermetabolic lytic lesion involving the proximal shaft of right femur with associated soft tissue component, and metabolically active lesion in the left iliac bone. There are no other sites of disease.
Okay. Okay. So how will you approach this patient?
I would do blood workup for chemotherapy fitness, ECG 2D echo also. First we'll treat it neoadjuvant chemotherapy, 9 to 12 weeks, followed by local modality, preferably surgery if resectable, with accepted functional outcomes.
So now you have everything. Now you cannot say if resectable. What do you
Yes.
think?
Resectable surgery followed by plus or minus RT based on post-op HP findings and based on the resection, whether it is R0 or R1 or R2 resection.
What about the iliac met?
The only site of distant met, sir. Single met. Oligo met.
Sorry, I couldn't hear you. The last thing.
Sir, that is the only site of bone met. And apart from the primary disease.
And where's the bone mat?
Left iliac.
Okay.
Do you have imaging of that by chance?
Sir, I couldn't appreciate that lesion, sir. Only local site I have made.
Okay.
So let's, for example,
that
if this is the scenario,
Sir.
so do you just presume PET scans report, or would you like to do anything else? So let me ask you something. Let me ask you something. That do you think that this metabolic lesion in the left iliac bone, will it be a disease or it can be something else? Can you see PET scan activity, hypermetabolic activity in non-tumorous lesions?
Inflammatory lesion.
Sorry?
Inflammatory lesions also be metabolic. Any
So what is
inflammatory.
Okay. So what is the basis of this uptake? How this uptake happens?
Where all is FDG concentrated?
No, but this is basic question. You should know. And this is not just orthopedic oncology. It will be required in every case and every patient you see. What is the basis on which FDG PET acts?
Based on the
Why it is show uptake?
metabolic, it might be marrow metabolic activity.
Why I'm asking you something else. Why do you get these metabolically active areas in non-tumorous lesion, or why these tumors get this uptake? This is a very basic question.
Anyone else?
Because of
Yes, sir, due to glucose uptake in the hypermetabolic areas.
Okay.
So any lesion or any activity wherever there's high glucose concentration or metabolically active lesion, it is not necessary that it is only because of the tumors. If there's infection, if there is inflammation, if there's any repair happening in the body, so wherever there is increased activity of the cells which requires more glucose to be taken up, there you will see this increased FDG uptake. So if you have had a trauma and if you do the FDG PET scan, you will see increased metabolic uptake. So having that uptake, you cannot just close your eyes and say that this is disease or this is a lesion or this is a MET. You need to ensure that you diagnose this. So how do you diagnose that? What are the ways? How will you rule out or confirm that it's a skip?
histopathology.
So there are two ways. Number two, you do another imaging, and that another imaging also substantiate the same. And second thing is what you said, that if it's a biopsiable lesion, you do the biopsy. Correct?
Yes.
Because your treatment will change. Whether you need to treat that area locally will change.
Yes.
Right?
Yes, sir.
Okay. I think a lot of people are leaving. Maybe they have to go for some other classes. So let's quickly go ahead. Yeah, Prabhat, go ahead, please.
Okay. So what chemotherapy will you give initially for 9 to 12 weeks that you said?
Initial chemotherapy, VDC, and basically what we follow here is VDC 2 cycles and YM 2 cycles, 2 weeks apart.
Okay. By any chance, what was the evaluation of that iliac lesion?
That was not evaluated further in this case.
Was there a history of trauma?
No history of trauma.
Okay.
Patient was treated with curative intent only, started on NACT.
Okay. And response after 4 cycle?
Yes, we after 3 cycles, the patient has defaulted and presented with paraparesis and
okay, leave aside this case then. Supposedly, he has only partial response at both the sides.
Yes.
What imaging will you do to assess response after 4 cycles?
MRI, and for this skip lesion, we'll repeat PET CT.
Okay. Will MRI, the pelvis MRI, give you any other further information?
Use information regarding resectability and resectability of the primary lesion.
Pelvis, I said. Not femur. Okay, that could have given us an idea what the pathology of that iliac lesion was at baseline, what Dr. Ashish was saying. Okay, so if on repeat scan, supposedly that the iliac lesion at baseline was non-metastatic, and at repeat scan this patient gets complete response on PET CT scan, how will you proceed further after induction? Dr. Bhavsai is asking, will you do a bone marrow biopsy for this patient at baseline?
Baseline, we won't do bone marrow biopsy.
Why?
PET CT did not show any marrow uptake.
Okay. Sensitivity for PET CT scan for bone marrow involvement? Is close to 100%. Okay.
Yes.
That is why we have avoided doing a bone marrow biopsy now.
Yes.
Okay. After the original iliac lesion was not a metastasis, and now after 4 cycles, this patient has got a good response, complete metabolic response. How will you approach this patient? Local treatment, what would be your preferred modality?
Preferred modality will be surgery.
Why?
Surgically.
What other options that you have?
Radiotherapy, the other option, sir.
Okay.
Issues
And
with
what will you choose?
surgery, sorry.
Why?
Because of radiotherapy, there might be chances of second malignancies, and there may be growth disturbances.
He's 16 years old.
Yes.
Okay. Dr. Jifmi, if you can elaborate on RT indications.
The question, I just missed a bit. I just heard him say about second malignancies. So the question was whether he'll choose between surgery and radiotherapy?
Yes.
For local treatment. So whenever this is asked, I don't think so. You should put second malignancies as your first reason, because many studies have shown that doing surgery has an advantage in local control as well as other endpoints. So that should be your first answer. Though radiotherapy is a acceptable alternative, when surgery followed by plus or minus adjuvant RT when indicated has benefit, local advantage in local control as well as other endpoints compared to radiotherapy, definitive radiotherapy. So that should be your answer. Second malignancy shouldn't be your first answer. It can be one of the reasons, but it is not so. I mean, the incidence is not so much, and with the current techniques that are used for radiotherapy delivery, it is not as much. So if at all we are deciding on radiotherapy, it will usually be for tumors that are located that have a central location, that is vertebra and pelvis. Most of the times when the sites where you will not be able to achieve R0 resection. So in these cases, you will be giving definitive RT, and the doses will range between will be around 55 to 60 gray in 30 to 33 fractions. So it will be normofractionated, and there is the trial done by Dr. Laskar. It is yet to be, the whole paper is yet to be published, in which there has been dose escalation that is used against the standard dose, that is 55 gray. So there is a 25% increase in local control, though overall survival has not been shown to improve. So that is it. And talking about the volumes in radiotherapy, whenever so initially when radiotherapy was being practiced, we had been treating the whole bone that is involved. That is, we had considered to treat the whole marrow, considering Ewings sarcoma is a marrow disease. But then there was a trial done by Dr. Sarah Donaldson, in which she compared between the whole bone irradiation and only the focal RT to the lesion itself, giving margins. So that showed that the control was comparable, and hence now we practice RT to the lesion with adequate margins and not to the whole bone. So any other thing that you will want to know?
Some few words on adjuvant RT. Few words on adjuvant RT.
Okay.
When
so,
indications when we give
because the question was about definitive. Okay. So
no problem.
For adjuvant RT, so the indications for adjuvant RT it will be clearly margin positive microscopic or macroscopic disease left after surgery. The second one will be when the necrosis is kind of a relative indication. So it is when the necrosis is poor. So there are different studies which have coded adequate necrosis as 90. Some studies have said 95 to 99%. So anything less than 90 should be considered as poor histological response to chemotherapy. So having said about histological response, that shouldn't be the only indication to give RT or to omit RT. So it should be put in perspective of multiple other factors as to what the site is and what the surgical resection has been. So it should be looked into all these, and so ultimately what you're trying to see is the risk versus benefit. Why I'm saying this is because we know that when the necrosis is less than 90%, we know the outcomes are less, and that is why adjuvant RT has been indicated. But in certain sites like femur and humerus, where you can get good margins for the bone as well as circumferential, in our hospital, it needn't be that all patients less than, just because the necrosis is less than 90%, you will want to give RT. Now, talking about the point of avoiding RT when necrosis is more than 90%, there is a recent study of the Ewing. It is a retrospective analysis of a prospective randomized trial for chemotherapy, that is Ewing. And so in that trial, they have retrospectively analyzed patients who have received RT despite the necrosis being more than 90%. So what they found is that there is an advantage even when the necrosis is 100%. So the assumption behind this, as in at least what they have discussed, is the probable reason will be that despite good, achieving R0 resection and the pathological report stating that it is 100% necrosis, probably when the tumors that have responded very well, especially those which would have had a soft tissue component, the tumor volume they have quoted as probably more than 300 centimeter cube. The surgeries done in these patients wouldn't have probably encompassed the pre-chemotherapy volume. So that is what the reason that they have supposed. So I just want to stress on this point that this histological response should not be the sole indicator to give RT, nor to avoid RT. It should be put in perspective of various other factors as to which site it is, whether it is a long bone where you would have got good margins to the bone as well as circumferential as well, whether it is a small bone. So if it is in a small bone, despite necrosis being more, you may have to give RT where you wouldn't have achieved wide margins. So this is about post-operative RT.
Even I used to think, meaning though we traditionally think those who are chemo responsive, they are radio responsive. So those who have poor necrosis, in fact, RT may not help in those cases. Now that you are also quoting those who have 100% response, RT helped them much better because both of us go hand in hand most of the places.
I mean, the assumption is that, Prabhat, see, there has been studies also which have said that less than 90%, that's why that whole point about histological response came about, as in whether
our approach should be other way around. Those who have good response should be given RT and not those who have bad response.
Any which way, so that is the recent study. So people criticize that you have just taken a good lot of, so they had actually in that study, they have taken only patients more than 90% necrosis. So 90 to 100. So that is what they have compared, and you may criticize saying that you have taken the good lot, and in them you're saying that 100% necrosis had the best benefit with giving RT. But this is what the reason that they have quoted, as in probably, which is actually, if you think logically also, it fits in, because if there was a huge soft tissue mass and you had very good response, probably how much you may have to go, I think Dr. Gulia will be better to say about how much margins would you give if there is very good response, and or maybe complete metabolic response and near complete morphological response to the soft tissue mass around the bone. So that is what the reason that they have stated. So when there is very good response, the resection wouldn't have probably encompassed the pre-chemotherapy volume, mostly in the soft tissue, surrounding soft tissue. So that is where RT helps.
So, Prabhat, can I ask one question?
Yes, sir.
This was regarding one comment which was interesting one, that in that study by Dr. Laskar, the local control improvement of 25% is absolute or relative?
Sir, it is absolute, sir. 3-year local control. So this has been published.
Hold on, give me a second. Give me a second.
Yes,
so
sir.
you are saying that local control improved by 25%, and
yes, sir.
There is no survival benefit.
No, sir. It is not significant. There is, I don't exactly remember the values of overall survival, but there was a marginal benefit, but it was not statistically significant.
Okay, so maybe highlighting that Ewings remains a systemic disease. Maybe, am I right?
Probably, sir. Probably.
Second one, my question which I encounter regularly, this thoracic Ewings.
Yes, sir.
And
you mean
chest wall Ewings.
Exactly, sir.
When do you give RT and how do you give it? Because it always
so sir, I'll
implies
first address the. Okay, sir. Okay, sir. So the first question about when do we give RT? So, sir, in central tumors, as in axial bones, you usually do not get a wide margin, sir. So when it is rib, be it rib or pelvis, the margins that you take on the bone and thinking that it is a central tumor, even if the resection is R0, you tend to support it with adjuvant RT.
So let me give you a situation which we commonly see.
For this, sir. Sorry, sir.
Sorry, Dr. Jose. I'll just give you the situation. So
yes,
if
sir.
it is only located to rib, perfectly fine, someone operates. Usually what we see, it is almost hemithorax with effusion being there.
Okay, sir.
And not all, significant proportion has a good response. My surgical colleague says clearly, no, Kumar, I am resecting what I am seeing.
Okay.
So we know that in chest wall Ewings, per primum, they never go back to what the original disease was. Not possible. But then, the intriguing part for me is, how do you plan your RT? Where are the places you give? You give to whole chest wall, you give to the lung. If you give only to the chest wall, anterior, posterior, how do you manage that to give only to those parts if the lung doesn't get exposed? Because if the lung gets exposed, then whole lung is gone. But I see wonderful results. The lungs are fairly preserved. Okay,
sir. So I'll answer this question in two parts, sir. First, we need to see where the disease is arising from and where it is involving. So we look at the index scan, and most often it is a tumor that arises from probably one rib, and it is actually giving a mass effect. I mean, it is growing into the thorax and pushing the lung to a side, with or without pleural effusion. So first I'll answer if it was without pleural effusion. So in these cases, we give chemotherapy, and most of the times it will regress towards the involved rib. So the surgical excision will encompass that rib, giving margins to the probably pre-chemotherapy involvement of that rib. And our RT in this case will be limited to that bed, sir, because we think, I mean, it is not we think, it is the compressive, as in the obstruct, what do you say? It is the mass effect that is caused by the tumor rather than involvement of the surrounding structures. So that is something that we really need to see. In this same case, if suppose there was.
Can I interject in that case?
Yes, sir. Yes, sir. Sure.
But that is not the philosophy you take in the lung cancer. It may be compressive when you have a given induction chemotherapy, shrinkage of the tumor. Do we take this philosophy because the possibility to ability to deliver the treatment, or we have certain reasons to believe it?
Sir, I am not exactly understanding your question, sir.
So
In
lung cancer, if I have a 5 centimeter tumor and if I given induction chemotherapy, it becomes 2 centimeter. My radiation oncology colleagues, they insist that we take original margin.
Okay, sir. So
I answer them the same way what you said. I say, hey, it could be compressive.
Yes, sir. So
they don't agree with me.
I would say that this would be, we may have to look at it in a way that it is a parenchymal disease, sir. So with chemotherapy, even if the gross tumor that you see radiologically has regressed, you may have these small.
Hold on, the same will be true here also then.
Not exactly, sir. I would say
you want to say that Ewings is not infiltrative disease?
So it will be, sir, to the surrounding soft tissue and the muscular tissue that is around, but into the lungs is rare, sir.
So, but it goes, actually, it is almost hemithorax. Most, no, I'm sure you manage, because radiotherapy goes to you guys only.
Yes, sir.
Almost 9 out of 10 patients, what we see is whole hemithorax involved. And then it intrigues us, how do you plan radiotherapy for these patients?
So that was the second condition which I did not speak about, sir. So
majority of them are hemithorax. So as you talked about small lesion, rib lesion with 3 centimeters, perfectly fine. But I'm not talking about that. I'm talking about whole hemithorax is involved. Now, how do you go about it?
So this is not actually a chest wall Ewings. So at times we do get such cases that you are referring to, sir. It is the entire hemithorax.
Not once in a while. And again, Dr. Josh, 9 out of 10 patients going from thoracic DMG is like this kind of tumor.
So let me just clarify, sir. This is not a chest wall Ewings, no, what you're referring to. It is a hemithoracic Ewings. That
we don't know. We see some rib lesion somewhere and we think, oh, it is a chest wall coming.
So
say that,
sir, we look into these factors, that if there is any infiltration into the surrounding muscular tissue, and lung is usually not infiltrated, sir, because it is just pushing it. If there is pleural effusion, what we do is, if there is significant gross pleural effusion, it may be proved with the cytology. But if there is gross pleural effusion, we consider that as involved. We do our radiotherapy. We plan our radiotherapy in 2 phases. In the initial phase, we treat the pleura, that will as in to a dose of 12.6 in conventional fractionation. And then we boost the tumor bed. So that is what we do, sir.
Oh, it's a pleural bed, the whole pleural bed you give, RT. Am I right?
Yes, sir. So, yes, sir.
So how do you ensure that the lung doesn't get exposed if you're giving the whole pleural bed, including anterior, posterior?
Sure. Yes, sir. So anterior, posterior was something that we still used to use before. But now when we have to deliver pleural RT, we treat with IMRT, sir. So
IMRT, so whole this area, the whole chest wall on the, for example, if let's take it right side of chest wall, the whole right side of chest wall, laterally, anteriorly, posteriorly, you plan in a way that only those thickness gets the RT. Am I right?
Yes, sir. So that is what we do, but we need to put into the fact that lung is something that is inside this tumor volume. It is like a what do you say, a cover to the lung. So then you should assume there's some dose that goes to the lung. It's not that there is 0 dose that goes to the lung. Lung will receive to around 60 to 70% of the prescribed dose to the pleura. So pleura receives around 12.6. Lung will receive around 7 to 8 gray, sir. 7 to 8 gray, yeah.
Thank you. That was very informative, Dr. Jose.
Yes, sir. And then we boost the tumor bed.
Okay, thank you.
Let me just add one more thing, sir. If there were parenchymal mets, lung parenchymal mets, then we would want to treat the lung also.
Oh, okay. Oh, thank you.
So we
because radiotherapy is given by your group, so our radiation oncologists, they keep saying us, but this was a very informative. Go ahead. You wanted to add something? Yes.
No, sir. So it is essentially how the tumors respond, sir. So we in chest wall Ewings, it is something that arises from the rib, and it is not actually infiltration to the lung. It is mechanical, as in it is a mass effect to the lung parenchyma. But in the case of lung cancers, it is inside the lung, and you should expect this even if what you're seeing, the gross residual disease after chemotherapy is what I mean. If it is, suppose it symmetrically reduces, you must expect some microscopic disease around, sir. So that is why pre-chemotherapy volume has to be included. I would suppose that is what differentiates why the contouring and treatment guidelines are different in these two cancers.
Thank you. Sorry, Prabhat, I took a bit of a time, but I thought this clarification would have been useful for our.
Yes, sir. I hope I answered your questions.
It was very useful.
Even I would like to add, if there is pleural effusion associated,
yes,
still we go ahead with RT. Many times it is. We don't evaluate also in Ewings. Looking at Ewings, we become happy and start treatment fast.
So, Prabhat, I don't think so. We have a very black and white answer for this. So we would look at how much the pleural effusion is. If it is gross, so you may have some reactive effusion at times, but that is likely to be very less. When you have gross effusion, it is unlikely that it's going to be reactive, and our sensitivity for cytology, even if we pursue that, is not, the sensitivity is not much. So we cannot just go by that, because we do see patients relapsing with pleural disease in chest wall Ewings sarcoma. So that is why we have this policy that if there is gross, I mean moderate to gross pleural effusion, or maybe there may be there might be a report with showing that cytology is positive. We will not actually go by only the cytology report, but if it is moderate and gross effusion, we will go ahead and treat the pleura. If there are pleural nodules seen in radiology, then I mean there's no need to see whether if there is pleural effusion or not. We go ahead and treat them with pleural RT.
Okay.
I hope I answered the question.
Yes.
Okay.
Okay. If Ashish Gulia sir is still around, he can throw some light on details of surgery. He will.
Sir is there.
Yeah, Prabhat. So nice discussion on RT, but I think a lot of the students will be confused on whatever discussion happened. So what do answer they give in the exam? So I think it is very important to give them, crisp bullets.
Okay, sir. So the indications, of indications for RT, if you have to say in 2 lines, you can say.
So the
R2,
important, what I understood from all this discussion, what students should remember is that presently wherever the disease is excisable, surgical resection is preferred over radiotherapy, and there can be multiple reasons for it. One of the reasons is that even with the dose escalation trial, even with the results of the dose escalation trial, we have seen that the local control rates are better with surgery. So if I remember correctly, if we compare our surgically excised pelvic patients versus dose escalation, we still had at least, I think, 10% better local control rates than.
Okay, so the local control in dose escalation was around 80. So, I mean, with surgery, usually it's around 85 to 90%. So
yeah, so it's still better. That is number one.
Sir. Yes.
Number two, what we should not forget is that there is no right answer for many things, because we are still learning and evolving. Euro Ewings gave an additional cohort where they started saying that, if we should add RT to each and every patient. But again, the kind of excisions which are done are also different. So excising the tumor completely is one of the very important criteria, and your margins don't change based upon the post-chemo evaluation. Your margins will always remain the same. If Vestus intermedius is involved by this tumor, the kind of tumor which you are seeing, irrespective of the mass or the shrinkage, that has to be excised. So, the margins don't change. Yes, the tumors which are not responsive to chemotherapy will anyways have a bad prognosis, irrespective whether you add radiotherapy or you do not add. But when you are asked in the examination about the indications for adjuvant radiotherapy, you would say that any tumor which was a very high volume tumor to begin with, where the margins have been very closed or compromised, where the necrosis is less than 90%, and patient who had pathological fractures. So these are the 3 or 4 points which you must mention in your exam, because these are very clear where you will add radiotherapy. Now, in addition to that, there are some trials which might add. Now, Americans behave completely different. They don't add radiotherapy at all, and still their results are same. So it's a bit confusing. So I don't want to confuse the students a lot, but these are few points which you should remember and should mention in the examination. Wherever we talk about long bones, in Ewings sarcoma, the rate for amputation is very, very low, given the fact that these tumors are pretty chemo sensitive. So the mass decreases a lot and we can perform surgery. And if not, then we have backing of radiotherapy, and hence amputation cases in Ewings sarcomas are very less. Main indications for amputations are non-responsive tumor to chemotherapy and tumor presenting with fungation. In limb salvage, you all know that we have megaprosthesis, which are one of the most commonly used options for reconstructions whenever we are doing resections which involves part of a joint. If you have tumors which are in the middle of the bone, like the case which we saw today, you can do something called as intercalary resection, where you preserve the bone above and below and you remove the middle part, and there you can use the same bone after sterilizing it with radiotherapy, or nowadays we are very frequently using liquid nitrogen to sterilize that bone, and you can reimplant it. So that is called as reimplantation of sterilized tumor bone. You can do that, or you can use metallic prosthesis there as well. So I think even if they mention that this much, they should be okay, Prabhat. And if there are any specific queries related to surgery, I'll be happy to answer.
No, sir. Thank you for your guidance. I think we will end our session here, because chemotherapy details they will learn in OPD, and I've taken a class yesterday.
Yes.
Okay. Anything else students wants
Thank
to
you.
ask? Okay, sir. That's it.
Thank you.
Thank you, sir.
Thanks.
Thank you, Jifmeet. Thank you, Amit sir, and thank you, Poonam.
Thank you.
Happy New
Thank you
Year
so
to all.
much.